Good morning. It's nice to see all the animated discussions. I apologize for breaking them up, but we would like to begin the second session so we can stay on schedule. So if you would have your seats, I would be very grateful. Thank you. It gives me great pleasure to introduce the speakers for the next session: persistent postoperative cognitive dysfunction, decline, myth or reality. The first speaker, Jacob Steinmetz, who is a consultant in anesthesiology and a senior researcher at Riggs Hospital and the University Hospital of Copenhagen, and associate professor at the University of Copenhagen. His PhD was on postoperative cognitive dysfunction, and currently he is also doing research in relation to trauma and pre-hospital emergency medicine. We're happy to have Dr. Steinmetz speak.
Good morning, everyone, and thank you for the kind invitation. It's actually my first time here in windy Chicago, and this morning also rainy Chicago, so please excuse my wet hair, it's not dry yet. So the next couple of hours, we just heard about target control infusion, and I'm happy to say that the next couple of hours we're going to talk about the godfather of all target organs. It's going to be the brain. And so it should be important for those of you interested in pharmacology and pharmacokinetics. So it's a very long title, but I'm supposed to give an overview of this area and using the lessons from the ISPOCD studies. As said already, I work in Copenhagen in Denmark. First of all, I'd like to declare that I have no conflicts of interests. There's not a lot of money involved in this field, actually. So I'm dividing my talk into talking a little bit about the collaboration, and then something about neuropsychological testing and the condition postoperative cognitive dysfunction, and then a little bit about the cognitive trajectory. But first, let's talk about the international study of postoperative cognitive dysfunction. It's usually abbreviated ISPOCD or ISPOCD, and to date it's the largest studies on postoperative cognitive dysfunction. It enrolled more than 2,500 patients in more than 25 centers all over the world, mainly in Europe, but US was also involved. The ISPOCD-1 study was carried out in the mid-90s, and the ISPOCD-2 was several smaller studies, and they were carried out in the late 90s. So assessing cognitive dysfunction is not as easy as it might sound. You cannot take an X-ray, you cannot take a blood sample, and there's not a general opinion about how to assess it. So, but I'll start off by giving you a case to tell you what it's all about. It probably illustrates the problem a little bit. Some years ago, I talked to a 77-year-old man who was supposed to undergo hip surgery, and the day before the surgery, he performed some neuropsychological tests. One of the tests was in the mini-mental state examination test, which is usually used to assess whether or not a patient has dementia. One of the tasks in the MMSE is to draw these two pentagons as exact as possible. And although you can see that he did not perform it to perfection, he had a good idea of what the task was about. So the one on the left is a square, but actually the one on the right is a true pentagon. So a week later, I went to talk to the man again, and it was just an hour before he was supposed to be discharged. He seemed perfectly normal to talk to. He seemed the same as 1 week previous, but he had he struggled a lot doing all the neuropsychological tests. So I gave him this test again, and this was his performance 1 week after the surgery. It was quite clear, not only to me, but also the patient himself, that he performed poorly, so he asked to repeat the test again, and this was his second attempt. And I think it's quite concerning. So it's quite clear that there is a problem, and this problem is some kind of postoperative cognitive disorder. So doing neuropsychological testing, most researchers agree that there is not any golden standard, but most agree that you need a whole battery of tests in order to assess different domains. So you have memory, attention, information processing, concentration, and you need different tests to assess different domains in the brain. We believe, at least in the ISPOCD collaboration, that every patient should be his own baseline, because there's a large variation within normality. You can be normal in many kinds of ways, so it's important that the patient is his own baseline. We also believe that it is important to use control groups in order to get an idea of what the variation from session to session is, and to adjust for learning effects. So every time you perform a test, usually you will become better. But so in that sense, it's important to have a control group, because the lack of improvement can actually be a deterioration. Okay, so if normal persons not undergoing surgery would usually improve significantly in a test because they repeat it, then if you stay the same, it will be a deterioration. And most researchers also agree that, as said, you cannot do only one test. Sometimes, unfortunately, you see in the literature on this subject that the researchers carry out only one test because it's very quick. And the problem in this field is that giving a whole battery of tests take a long time. It usually takes like 30, 45 minutes. So it's tempting to only do one test in 5 minutes, but it's not going to give you a whole good idea of what's going on, actually. So you could say measuring reaction time will not give you an idea of memory. Using questionnaires is also probably not good. You tend to forget that you forget. It's usually not the demented patients that are complaining about the dementia. It's usually the relatives that notice better. And in the ISPOCD study, they showed that there was a poor correlation between self-assessed cognitive dysfunction and actual cognitive dysfunction. So it's if you're saying to yourself, "Oh, I keep forgetting," then you probably don't have a problem. So you should be relieved. I won't be quoted for that. Okay, so I'll just talk a little bit about the ISPOCD calculation, and we are where, I mean, we were dichotomizing POCD, and that can be good and bad, like dichotomizing hypertension. So then we do not see the different severities of cognitive dysfunction. On the other hand, it can be a clearer message. So we used, well, in the ISPOCD studies, we used 6 tests, but only 4 of the tests were used in the calculation of whether or not the patient had POCD or not. So we calculated a C-score, and you needed a C-score above 1.96 in at least 2 tests, or a combined C-score in order to get the diagnosis, you could say, POCD. So the calculation of the C-score is the difference between the preoperative and the postoperative session in that test, and then you subtract the expected change from the control group not undergoing surgery. So you see what the control group is doing, and then you compare it with what the patient undergoing surgery is actually doing. Then you divide that number with the standard deviation for this change in the control group. And that will give you an idea of whether or not the patient has POCD, and the reason for having a C-score above 1.96 is, I mean, it's a comparison to the 5% significance level. But as you can see, we believe that, again, it's important to have a control group in order to get the normative data. Okay, I'll give you an example of one of the tests we use in the ISPOC studies. It's called the Stroop color word interference test. And as you can see, there's a lot of words here in colored letters. And the task is to say the color of the letters rather than the actual meaning of the word. So the patient should be saying yellow, red, yellow, blue, green. I'm always very eager to do it myself. But I think I went fine, right? But then you measure both the time for performing this whole sheet and also calculate the number of errors that the patient makes. So 2 variables performing this test. But it's important to understand and acknowledge that there's not one test that is suitable for all patients. So you need to know whether or not you're looking for very subtle changes or whether or not you're looking for broad cognitive changes. Like the mini-mental state examination test, that's very general. It's not very sensitive for subtle changes. And one of the problems to illustrate that from an ISPOC study is a study by the late Jeff Silverstein, who looked at the data from the ISPOC-1 study, 1,200 patients, and because we did not assess mild cognitive impairment, which is just before dementia, you have mild cognitive impairment, we tried to define another group with preoperative cognitive impairment, and we defined it as patients that scored below 1.5 standard deviation below a control group. And we found that none of these patients deteriorated more than 2 standard deviations in the memory test. So they could not have, in that test, they could not have cognitive dysfunction. So this is an example of a test that is not very suitable for patients being cognitively impaired. And that is one of the problems with the cognitive research in general, that you tend to enroll only the patients that are motivated and that do not have cognitive impairment, but maybe those are not the patients that are really interesting. So you want to have the frail patients also, and it's difficult to measure these patients. Usually also in cognitive research, you only enroll the elective patients because you need a baseline score before the surgery, and that is difficult. They are already cognitively impaired if they are acutely admitted. So this is an example of a floor effect. If you are presented 15 words and you only remember, if you're only able to remember 3 words before the surgery, then it's impossible to get a 2 standard deviation deterioration because you cannot remember less than 0 words, right? Okay, so something about the condition postoperative cognitive dysfunction. Usually you say that it's a subtle condition and it's in lack of clinical symptoms, and usually the consciousness is unaffected as opposed to delirium where the consciousness is affected. Usually in POCD the memory and the concentration domains are affected, and it usually lasts some weeks to months after surgery, and probably it's largely reversible. I'm gonna come back to that later. So the ISPOC-1 study, the first study on international study on postoperative cognitive dysfunction, was by Jakob Trier-Müller from my department and colleagues, and it was published in Lancet in 1998. And they showed out of the 1,200 patients that were above 60 years old undergoing major surgery that 25% of those patients had POCD 1 week after surgery, and that incidence fell to 10% 3 months after surgery. They also assessed different risk factors, and as you can see on top, age is an important risk factor across most studies on POCD. And also you can see down on the bottom here that you have education, which is a sign of cognitive reserve. So the better educated, the less risk of POCD you will experience. But interestingly enough, they also assessed whether or not hypoxemia and hypotension during surgery would be a risk factor. And interestingly enough, they did not find an association. So that was contrary to the belief at that time, I believe. It was hypertension was confirmed a year later by Williams Russo, not showing an association either. But as you can see, duration of anesthesia is also a risk factor, and as you're interested in pharmacology, you can say that there is kind of a dose response. So the longer the anesthesia, hence the longer the surgery, then the higher the risk of having POCD later. So for every hour you have surgery, there's an odds ratio of 1.1. So to the right, you can see the ISPOCD study by Jakob Trier-Müller that showed a 25% incidence of elderly patients above 60 undergoing major surgery. So in the ISPOCD studies, they assessed different groups of patients, and they found that there was also a high incidence of POCD in middle-aged patients between 40 and 60 years old undergoing major surgery. That's published by Johnson. And Canet from Spain published a study showing, interestingly enough, that elderly patients above 60 years old that underwent minor surgery had a very small incidence of POCD. And as a secondary outcome, he also showed that outpatients had less POCD than inpatients. So I believe that before that, you would probably say this is a frail patient, we better admit the patient before surgery. Then after that study, you would probably say this is a frail patient, we better get him under the knife in outpatient clinic. So it's hospitalization probably plays a role. So a lot of other ISPOCD studies try to assess different other risk factors that you thought would give cognitive deterioration, but they did not find an association. So Lars Rasmussen published a study showing no association between the use of benzodiazepines before the operation. He also published a study showing that neuron damage measured as a neuron-specific enolase and S100 beta did not show an association to cognitive dysfunction. Interestingly, they found, though, that S100 beta, there was an association to postoperative delirium. Han Abelstrøm showed that there was no association between the apolipoprotein E gene that is associated to Alzheimer's disease dementia, but that was not associated to POCD. And we showed that having polymorphisms in some of the P450 encoding genes did not show an association to POCD either. Famous study by Lars Rasmussen. It was a randomized study where they randomized 400 patients to receive either regional or general anesthesia, and they did not find an association between whether or not the patient had regional or general anesthesia and later POCD, at least when they looked at the intention to treat analysis. However, when they performed the per protocol analysis, then they found a significant association between the use of general anesthesia that would significantly improve the risk of having POCD. So unfortunately, not all the patients that were allocated to a specific type of anesthesia received the anesthesia. That was why they performed the per protocol analysis. But it is the common belief, though, that regional anesthesia will not provide less cognitive disorder after surgery. So nearly 20 studies, randomized control studies, they failed to show a beneficial effect of regional anesthesia. So that is probably the common belief. So what about the cognitive trajectory? So this is a slide illustrating what it might be. So you have surgery, then in the hours afterwards you have recovery, then usually 2 to 4 days after surgery, you have a postoperative delirium. Then in the weeks and months after surgery, you have postoperative cognitive dysfunction. And at least hypothetically, in months to years after surgery, you have dementia. Actually, it was described in the 1950s by Bedford in the Lancet, probably showing some patients having dementia after surgery. So Hanne Abelstrøm, she published a study in 2000, which was a long-term follow-up of some of the Danish ISPOCD study patients, and she assessed them 1 to 2 years after surgery, and actually nearly one out of 5 refused to perform the follow-up assessment. And those are probably very important and interesting patients because it might be due to cognitive impairment, so we don't know what's going on. It's a black box. But the rest of the 80% of patients, they only found 3 patients that had POCD at all 3 time points. So it's important to remember, actually, this is not, it's not written in stone that it's only half the patients that if you have POCD 3 months after surgery, only half the patients actually had POCD at the 1-week assessment. So you can go back and forth, and it's not that specific, actually. It might be the same with hypertension. If you have a blood pressure of 145, then the day after it might be 135. Okay. So, but only 3 patients out of the 330 patients assessed had POCD. So that made us to believe that it's probably a transient condition, and it persists only in 1% of patients. If it was purely by chance, there would only be a 1 out of 64,000 risk chance of having testing positive at all 3 time points. So it is probably 3 true POCD patients. What about delirium? There was a study in 2008 by Rudolph showing that postoperative delirium was associated to POCD 1 week after surgery, but again, it was a problem that if you had delirium, then you were less likely to perform the neuropsychological tests. Those are interesting patients as well. They did not find an association between postoperative delirium and POCD 3 months after surgery. We published a study some years ago on the risk of having POCD 3 months after surgery, showing a 60% increased risk of mortality after surgery. As you can see, the 2 lines separate. So the red line is representing patients with POCD 3 months after surgery as compared to patients without POCD, and this difference was significant. We also showed that if you had POCD 1 week after surgery, as represented by patients in the red line here, you had you were more able to, well, you tended to leave the labor market prematurely, and we also showed an association to receiving social transfer payments, social subsidy. A lot of people in Denmark have that. You don't know that too much in the States, do you? So we receive more social transfer payments if you had a POCD 1 week after surgery. So back to the slide on the time course, the cognitive trajectory. This is still questionable. So is there risk of having dementia after having POCD? A couple of years ago, we published a study of 700 patients from these POC 1 and 2 studies that we follow up for 14 years, and we did not find an association between POCD at either time points and later dementia. But fortunately, only 32 patients had dementia out of the 700. So it can be a type 2 error. It can be too few patients to assess for that, because actually you see the point estimate is above 1. So we calculated that we should have needed probably 8,600 patients in order to make the point estimates significant had it been true difference. Okay, so we do not know about that. So, in conclusion, I think it is fair to say, based on the ISPOCD studies, that postoperative cognitive dysfunction is a common and a severe problem, and that age and type and duration of surgery are important risk factors, whereas the type of anesthesia, hypertension, neuron damage, and polymorphisms are probably not apparent risk factors. POCD is associated with an increased mortality and retirement rate, but it's probably not associated to an increased rate of dementia. Thank you for your attention.